All right. Well, like I said, I think we've done an episode or two kind of going over the same structure, but I want to go through specific conditions,
Okay.
and then you're going to tell me what symptoms typically occur. You're going to tell me what the client should tell their doctor or how the client should talk to their doctor about that condition. And then what is the best type of evidence for their case. And again, just as a disclaimer, we're not listing off conditions to where if you have this, then you definitely qualify. It really
Right.
depends on the symptoms and it depends on a bunch of other things.
The severity of the symptoms, big
Yeah, the
time.
severity of the symptoms. It has to actually prevent you from working. It can't just be something that's inconvenient.
Right.
So, with that in mind, it has to actually prevent you from working. But we'll go over a couple other. Either way, we'll go over some common conditions. So, first one I wrote down is heart disease. Typical symptoms? How should they talk to their doctor? And then, what is the best evidence for someone to win their disability case if they have heart disease?
Right. Well, there's lots of different heart disease. There's coronary artery disease. There's heart arrhythmias where you're missing a beat or you've got too many beats. Um, the symptoms that we would be looking for, there's going to be shortness of breath, cardiopulmonary problems. The best evidence is probably an EKG, which is that's the main heart test, a chest X-ray to see if you've got cardiomegaly, which means your heart muscle. Because it's a muscle, like any other muscle, if it's working really really hard, it gets bigger. Megaly just means it's bigger.
Yeah.
So you'd be looking for that. The symptoms that we'd be looking for would be a problem with stamina, shortness of breath, maybe lightheadedness, dizziness. And what you'd want to talk to your doctor about is any of those if you were experiencing any of those. Listen, when I get up suddenly, this is like POTS. And don't ask me to give you the what that stands for right off the bat.
Yeah.
But it's literally a fainting or a near passing out whenever you get from one bodily position to the next. Usually you're coming down and you're getting up.
Mm-hmm.
That's a cardio problem. Your blood and the oxygen and everything like that is not responding as quickly as it should be. But you can tell your doctor about any of these kinds of things. I'm short of breath. Wait a minute, do you smoke? No, I don't smoke. And maybe they'll do a chest X-ray and they'll see your lungs are clear and they'll be like, well, he's short of breath, but he doesn't have any kind of strictly respiratory problems. And then they'll go to cardio problems, do an EKG probably. Listen to your heartbeat to see if you have any rubs or gallops or anything like that. These are just abnormal heart function. But the big thing we see is lack of stamina, shortness of breath, some dizziness, lightheadedness. Any of those things are symptoms that could be disabling. Again, like you said, your disclaimer is spot on, which is the symptoms have to be severe enough that they would keep you out of work, and we'd want to see that in the medical records. And cardio problems, they extend to circulation problems also. So you might have some problems in your extremities. If your heart's not pumping like it should, they'll do a cardio a catheter. They can do that. They can do an echo. These are all just typical, not really out of the ordinary cardiac studies to see what your ejection fraction is. The heart should be pumping a certain percentage of blood, and that's extremely important because if it's not, you probably are going to be dizzy, or you're probably going to have some kind of weird feeling in your extremities, because that's where the blood has to get to. It's the furthest part from your heart would be your extremities, which is why they're called extremities. But they'll do, they can do an ejection fraction study with a cath or an echo, and what you're looking for is an ejection fraction that's 50% or better. And you're like, wait a minute, that's only half function. Well, not really. I mean, it's kind of weird. If you got a heart condition, but your ejection fraction is, 50 to 60%, you have a heart condition, but it's probably not going to be disabling. Certainly, that kind of diagnostic study wouldn't go very far. However, if they did a ejection fraction and you're down to like 30-35%, that means that your heart is not pumping as much blood, not as much oxygenated blood as it should be, and you're going to have some problems. You're going to have that dizziness. You're probably going to have some tingling, loss of feeling in your extremities. So that's what we would be looking for.
Yeah, I've talked to people that have their ejection fraction is like 15%, which is extremely low, right?
Yeah, we've talked about the listings before. The listings are kind of the black and white thing. If Social Security says, if you meet a listing, it means that in their listing book they say you have a cardiac condition and you've had an echo, you've had a cardiac cath, and for a period of time, usually 3 to 6 months, your ejection fraction has been 25% or less. That's listings level. So if somebody came to us and said, my doctor says my ejection fraction is 15%, 15%, it's like you probably should be hospitalized.
Yeah.
You're talking to us, but you probably should be hospitalized because your heart is you're essentially in heart failure at that point. And hopefully they would have you on some medication to kind of jumpstart the heart.
Right. Okay. So yeah, main symptoms to look out for, typically shortness of breath, any kind of stamina issues. And then how that's going to manifest in your ability to work is you have trouble lifting things, you have trouble walking, you have trouble standing, that kind of stuff. Maybe your doctor is specifically giving you a weight restriction. I don't want you lifting over 10 pounds.
Right.
There's not a lot of jobs where I can't lift over 10 pounds and then they'll still hire you full time.
Right.
There's a few of them, but it's much harder, especially the older you get.
Absolutely.
So stamina issues, best evidence is if you actually get the scans done. So you go to your primary care doctor, or if you have a heart attack, you go to the ER.
In the hospital, yeah.
And then you eventually get referred to these scans like the EKG, and you talk to a cardiologist about it. So that would be the best evidence, right?
Right, exactly. Okay. And the MI, the myocardial infarction, which is the fancy name for a heart attack, the symptomology is going to be the same. Afterwards, after they've addressed the heart attack, if there are residual problems, which there usually are, they're going to be stamina, they're going to be shortness of breath, might be chest pain, angina, which a lot of people say angina, but it's angina. Angina is chest pain. That's the medical term for chest pain. And classic cardiac chest pain, it's very, very specific. It starts in the chest and it shoots down the left arm, always the left arm. And what would happen is if you went into a doctor's office, they would say something like typical anginal pain, typical chest pain. It's running down into the left arm, sometimes up into the left part of the neck. If it was going into the right arm or it was just staying in the chest, you'd probably read something like atypical chest pain, atypical angina. So, but if you're having, anginal symptoms, if you're having it a lot, you're not going to be able to work because, chest pain is like any other kind of pain. It's going to mess with your ability to function. It's going to mess with your ability to concentrate. It's going to mess with your ability to stay focused and be able to complete a task. Nitroglycerin, if you've heard that people with heart attacks, they use the nitro tablets under their tongue. That's specifically to address chest pain, anginal pain. So those are other symptoms, and that's what we're looking for them in the case record. We're looking for a description that are typical of a cardiac condition.
Okay, and then next condition, COPD, and it's going to be the same answer whether the client has chronic bronchitis or emphysema or maybe lung cancer or severe asthma. But COPD is the one that I hear about the most for whatever reason. So, yeah. Main symptoms, how to talk to your doctor, what's the best evidence for a COPD case?
Best evidence is, the absolutely tipper top of the most best evidence is a pulmonary function study, a PFS. And if you've ever done one, or for anybody who's watching, the machine is kind of like a breathalyzer.
Mm-hmm.
I've never been pulled over for a DUI. I never had to do that. But for people who have, I've seen it on videos. It's a very small straw, kind of a tube, and it's got resistance. In the machine has resistance in it. You just can't blow through it and stuff like that. You blow really, really hard, and your cheeks will flare up because you're blowing and you're getting that resistance. And the machine, a PFS machine, is measuring, one, your lung capacity, and it creates a curve. You know, how far, how long could you blow? What does that mean? Your expiratory, blowing out. How was that? Was it normal? And of course, they give it a numeric value, and the lower that numeric value is, the worse your condition is. That's the best evidence. In fact, Social Security will buy you a PFS if they believe that your COPD or your bronchitis or even your asthma is possibly listings level. And again, the listings will show, depending on your sex, if you're male or female, and your height. You know, how tall are you? This is what your forced expiratory volume should be, FEV. Your FEV should be this, and it's right there in black and white. It's the listings, and if it's that or less, you meet a listing, and they're going to allow your case. What we normally see, we've seen some of those. We do handle some listings level cases from time to time, but a lot of times they're either, especially these respiratory cases, they're either not on the chart, or they haven't had an FEV1, which is the forced expiratory volume, at a second, I believe is what the one stands for. But they haven't had a pulmonary function study, or they've had one and it wasn't done the way Social Security likes. Social Security likes you, or well, if you ever have them do the study, you have to do 3 studies without any kind of medication. If you're on an inhaler, no, you're going to blow into this tube. You're going to do it 3 times, and then after that, they're going to give you a bronchodilator, and then it's going to probably open up your airways, because that's what bronchial dilators do, those inhalers. And then they're going to do the same thing. But and your post bronchial dilator values should be higher, because everything should be opened up. And if it's not, you got a pretty significant problem going on. So if you've done like a pulmonary function study at a hospital, you went in for an ER and you could barely catch your breath, and they had you do one. They almost always will just do one. You blow in it, you get the reading, and it's okay, well, and that's all they do. Whereas Social Security is like, no, you have to do 3 without a bronchial dilator, and then 3 with, if there's some severity showing. Of course, if you did it 3 times and the volume, your expiratory volume was huge, there's no reason for you to even administer a bronchial dilator, because you're doing fine. So but there will always be 3 with Social Security, at least 3, sometimes 6, if they do the bronchial dilator. So what you want to tell your doctor is, I'm having trouble breathing, and keep in mind that just the way that God created us, everybody becomes short of breath when they exert themselves. I will challenge anybody watching the video, hop out, put your tennis shoes on, hop outside, run around your property 3 times as fast as you can, and then take a video of what you look like afterwards. And if you do it all the time, if you're just a runner, you're still going to be out of breath. That's normal. That's not what COPD is. COPD is a leisurely stroll to your mailbox that might be 40 feet away from your front door, which is not much. It's like not even a little league home to first base, 40 feet. And halfway there, you're panting. You have to stop. That's significant. Or I ask this in almost all my hearings where there is a respiratory allegation. If you have COPD or emphysema, bronchitis, chronic bronchitis, do you ever become short of breath just sitting around? Like if you're watching TV, you watch an episode of something, and you have to hit your inhaler. Does that ever happen? Oh, yeah. How frequent does that happen? I have to do that probably 2 or 3 times a week. Okay, that's something that you would see in somebody with COPD. There's no real reason for them to be getting winded or short of breath, and yet they are. They're just having a hard time with that. I do want to say this. It is extremely damaging to your case if you have a problem with COPD, emphysema, bronchitis, asthma, anything like that, and you're still smoking. In fact, the first question out of the judge's mouth when they're asking you about your impairments will be, do you smoke? Or if they see it on the case record, are you still smoking? And it's damaging to your case because the judge is going to ask this question. Well, have your doctors told you to quit? He asked that question, but he knows the answer already. You know the answer already, that every single time you've gone into your doctor complaining of shortness of breath and he smells cigarettes on you, you need to quit. I know, well, you need to quit. And then the judge is going to ask you, has the doctor told you need to quit? And you need to tell the truth. Yeah. But it's an addiction, and some of the judges are pretty understanding about the hold that people, the spell they're under with nicotine and other kinds of addictions. But it is damaging to your case because it is something that you're choosing to do. You're smoking, and you're still short of breath, but you need to tell your doctor. Go into the mailbox. I can't even do that. Or I was sitting around watching my favorite episodes of Seinfeld, and I just I'm watching this show. I'm not excited or anything, and the next thing I know, I'm having to hit my inhaler. That's the kind of evidence that we would be expected to see in somebody who's got significant COPD.
Yeah, and then going back to whether or not they're smoking, like we were talking about in the last episode that we did about substance abuse, same thing applies. It's not an automatic denial. So definitely don't apply for benefits and say, well, I have COPD, but I'm still smoking. I can't tell them that I'm smoking or I'll just get denied automatically, so I'll just lie about it. That's not the right perspective. No. You got to be truthful. It is going to damage your case if you're still smoking. But what's going to damage your case even more is if you just lie to us and you lie to Social Security.
Yeah, because they'll see it in the medical records. And, I don't know if this is true or not, but I've seen it posted several times that the 2 most addictive substances on planet Earth that are used, we're not talking about opiates or anything like that right now, but we are talking about just common kinds of addictive substances, caffeine and nicotine.
Yep.
And a lot of the judges, they might ask a follow-up question, which I think is extremely fair of them to do. Mr. Smith, you still smoking? Medical record shows me. Yes, Your Honor, I'm smoking. Okay. You expected the question. You answered it honestly. Expect this. What have you done to quit? I mean, what kind of attempts have you made to quit? And when you start talking about attempts, like, I've tried the patch, I've tried the gum, I've tried this, I've tried that. And, I used to smoke 2 packs a day. I'm down to 10 cigarettes a day, which is half a pack. That probably is not going to be damaging to your case because it shows that you're trying to actually address the situation. And it's not going to be damaging to your case for you to have cut down so much that the medical records show it. The doctor asks you the same question, what are you down to? About 10 cigarettes a day now. Okay, half a pack a day. But you're still having those symptoms. So you're right. I mean, it's probably going to damage the case, but it's not going to be a deal killer.
Okay. Third condition, we've spoken about this one a few times, and it'll probably be a little bit more straightforward, but cancer. And I won't mention any specific type of cancer, but I'll just say cancer as a whole, and then you can kind of explain the differences, because there are, having cancer and then you get it removed and you're good to go, you're back to work within a week. That's very different than end stage, lung cancer or brain cancer.
Right. What we're looking for in the medical records is a pathology report. That's going to be the thing, a biopsy. Biopsy is going to tell you, you got it, and what kind it is. Is it an adenocarcinoma? Is it a sarcoma. There's all sorts of different kinds of cancers. But really the telltale sign of a significant cancer, I mean, they're all significant, but one that would be expected to be disabling would be one that has metastasized. And again, the pathology it usually shows that by saying, we have a biopsy of the left lung, which shows, adenocarcinoma and primary site undetermined. It's like, oh no, so you got lung cancer, but it came from somewhere else. And then they'll do some exploration and they'll find out the primary site and then the metastasized site. And you don't have to remember this, but since you asked, usually what they're looking for as far as a spread, metastasize, is beyond the regional lymph nodes. So pretty much any organ that you have, your lungs have the pleura, which is a sac that holds your lungs. They're looking for metastasis beyond the regional lymph nodes, beyond those areas that are just surrounding the organ that might be affected. That's usually what they're looking for. Of course, when you're talking about brain cancers, you're usually talking about blastomas, and that's a little different. It's significant. And then when you're talking about some cancers, like a skin cancer, they might have a primary site, or they might be the primary site. But usually, those will respond pretty well to treatment. So I don't know if they going back to work a week after you get something excised, cut out of you, is accurate. But with today's medicine, it's not far from accurate. Especially if it's benign. Benign means that it has not metastasized. It's its own cancer. It's not aggressively growing, and so that's what you're hoping for. But we'd be looking in the medical records for whether it's metastasized, and whether the primary site, and the secondary site, or could be secondary sites. And that's sad because that's really, really bad if it has spread to multiple different places. But that's what we're looking for. In this scenario, I wouldn't really say there's something you need to tell your doctor. Your doctor's going to be telling you stuff in a cancer case. They're gonna be recommending significant treatment, which would be excision, cutting it out, radiation, chemotherapy, things like that. So I don't think there's a whole lot of things that you'd have to be telling your doctor. Usually you'd be going to the doctor because, I was coughing the other day and I was coughing up blood. It's kind of weird. It's not COPD and it's not bronchitis. It could be several things. It could be lung cancer. It could be esophageal cancer, lots of things. And you'd be going to your doctor. And again, your doctor is the one who would be telling you, okay, well, this is what we found and this is how we need to proceed. But that's how we're looking at it. I say this, and it's just, 35 years into this, it's really strange to me that I do say this, but, so many cancers now are successfully treated that a lot of times, even if it was a metastatic cancer, they get the primary site or they excise the tumor from the primary site, they irradiate you, and you're taking chemotherapy, and 6 months later you're back at work, or 6 months later you're in a condition and position that you could go back to work. And it's just really hard for me to, I don't know if I can take your case, because you got to meet that 12-month durational period. And, either you haven't, or I don't think you're going to. I think things are going well for you. So, horrible for your disability case, great for your health. I mean,
Yeah, I remember when I first started doing this a couple years ago, and I would speak to clients that tell me they have cancer. I would pretty much, my perspective was, well, they have cancer, so medically that's good enough. Let's just put that down. But it really depends, because cancer could be treated. Is it active, or is it in remission? Has it spread? Has it not spread? Are you in chemotherapy or radiation therapy? It really depends.
Right, yeah. Somebody close has leukemia, and there's two kinds of leukemia. There's chronic leukemia, which is highly treatable, and this is what he has, and he's been on medication for probably 20 years, and his life expectancy is literally the same as anybody else.
Yeah.
And then there's acute leukemia, and that is horribly dangerous. And it's you wouldn't look at it the same way. Are they both leukemia? Yeah, they both are, but one of them is highly treatable, and one of them is extremely doesn't have a great mortality rate.
Yeah. Okay. Next one is that I wrote down is a mental health condition, schizophrenia, and we'll say any kind of psychosis, but schizophrenia.
Yeah. What we'd be looking for is probably with schizophrenia or psychosis, an inpatient stay. And I say that because if you are diagnosed, not necessarily with schizophrenia, like if it's a schizoaffective disorder, which is they kind of cross over into like a mood, emotional disorder, but straight out schizophrenia. You're hearing things, you're seeing things, you're thinking things that aren't true. You've lost touch with reality. And psychosis is really, that's played out in some way. If they're psychotic, there's something that they're doing that a sane person would not do. And they will likely either be picked up by the police, or their family is so freaked out by their behavior that they call and have them institutionalized. So we'd be looking for any kind of psychotic episode from schizophrenia or from any kind of psychosis. We'd be looking for an inpatient stay. What we would be very careful to see is if it was induced by drugs or alcohol, because we see that a lot. That they're like, I had a psychotic episode, and I was trying to stab my stepmother. It's like, oh my goodness. And you read the medical records, and he was high as a kite, and he was trying to stab his stepmother. That's a really hard case to win, because it's not so much a organic mental disorder. It's substance abuse basically sent you over the edge. But we'd be looking for that inpatient stay. Not always, but I'd say 90% of the time. If I didn't see that, I don't know if I'd want to take that case, because you rarely see ongoing mental health treatment with a therapist where they're saying, Mr. Smith is psychotic. It's like, are you allowing him in your office when he's psychotic? Because that means that he does not have a grasp on reality. He can be a harm to others, but more often he's going to be a harm to himself. He will maybe walk out in traffic. He might want to walk home. Well, he lives 10 miles away, but he wants to walk home. That's what a psychotic person would do. So we don't see that. I mean, you don't see medical records that are ongoing therapy where Mr. Smith is suffering from psychosis. There can be times where there are episodes of psychosis, and they report them in the therapy notes. The therapist says, I see a couple months ago you reporting that you saw some things that eventually you realized weren't there. Is that happening? Yeah, it happens every once in a while. We'd be expecting that for schizophrenia or psychosis, but not every time. Not every time you go in, because again, the therapist would likely sign off of this person needs an inpatient stay, kind of stabilize, bring them back to reality if they can. We would be looking for an antipsychotic medication. And in my humble opinion, and it is just my opinion, antipsychotic medication is probably that much better than the disease. A lot of times they say, the cure is worse than the disease. Well, the medication is a tiny bit better than the disease, but barely. The side effects of psychotic medication, schizophrenic medication, are severe. They're usually going to knock you out, or they're going to put you in a zombie-like state. I'm making a beeline to Seroquel. Seroquel is a very common medication for people who's they can't get to sleep because their mind's racing all the time. They can't get to sleep because they're anxious over things that they shouldn't be anxious about. I'm so anxious about blah 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 blah. It's like, wait a minute, that's not really even occurring. They're really, really just kind of on edge. And Seroquel, I've never seen it prescribed in a way where you take it when you get up. It's always you take it before bed. And the reason is simple, because you're going to be a zombie. You're probably going to wake up groggy from it, as a matter of fact, just because it's such an absolute strong medication. But you'll see that. And we'd be looking for that in any kind of schizophrenia or, psychosis. We'd be seeing that kind of antipsychotic medication. What do you want to tell your doctor? You got to be truthful. And sometimes it's really hard for somebody who has a psychotic condition or schizophrenia, or really any severe depression or severe anxiety. The things you have to admit to another person, usually a therapist or a psychiatrist or a psychologist, the things you have to admit are incredibly embarrassing. They're incredibly disturbing. I heard my grandmother talking to me last night. Oh, okay. Well, what did she say? Wait. I heard my grandmother talking to me last night, and she died 15 years ago. Oh, okay. Those are the kinds of things that you would hear from somebody with schizophrenia or psychosis. And that's the kind of stuff that you'd have to tell, what we're expecting to see in the medical records. That's what you would be telling your provider. I can't shut my mind off. I'm up for 3 days. People with a bipolar condition, most of the time in bipolar, that just means they're really, really high, anxious, on edge, or they're really, really low, all the way down to, wanting to harm themselves. It's bipolar. We see low, 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 bipolar, low, 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 bipolar, low, low. We rarely see bipolar, and my goodness, they're in a manic state. But somebody with psychosis in a manic state wouldn't sleep for 3 or 4 days. They're wired, their minds, and it's horrible on the body. Your body's, begging you to sleep, and your mind just won't shut off. We'd see that in case records, and you'd probably be telling your doctor that too. I haven't slept for 3 days. I cannot shut my mind off. So we'd see that. That's, those are really, they're not common as far as how many we see, but when we do see somebody with schizophrenia with a diagnosis, bona fide diagnosis of schizophrenia or psychosis, again, I almost always see that they've had at least one inpatient stay. They've been institutionalized at least once in the last 2 or 3 years, and they're being prescribed medication that turns them into a zombie. And my argument is, yeah, they're not, in a psychotic episode now. They're on medication, but the medication is so stout that you certainly wouldn't trust them to make decisions in a workplace. You wouldn't trust them to be safe in a workplace. You wouldn't trust them to make sure other people are safe in the workplace. I can make a really good argument on that, and that's what we'd be looking for.
Okay. Well, I think that's a solid place to end it. Make sure you talk to your doctors about your symptoms. Make sure you do your best to follow their recommendations. If they refer you to a specialist to get any kind of scans done, any kind of blood work, if they prescribe you medication, take the medication. And then, I think that pretty much covers it.
Yeah, good.
Cool. If you have a question about your disability case, drop it in the comment section below, and we will do our best to answer it in the next episode.